Good evening, everyone. My name is Schmidlen, and I am the genetic counselor for the Coriell Personalized Medicine Collaborative. My talk is going to focus on how to interpret your CPMC results for breast cancer. So first, I'll review the contributions of genes and environmental factors to breast cancer, followed by some discussion of the influence of other genetic variants on disease risk. I will also talk more about the specific genetic variant that the CPMC tested for breast cancer, the implications of a given result for your family members, and some of the limitations of CPMC testing. I'll wrap up with a review of some of the places where you can get more information about your results and about breast cancer. I want to start with an important reminder. The CPMC did not test for BRCA1 or BRCA2 or other rare genes that are associated with hereditary breast cancer. There has been a lot of coverage of these two genes in the media lately with the Angelina Jolie story, and I just wanted to make sure that everyone knows that we did not look at these genes. Our study is focused on genetic variants that are common in the population and that are contributing to sporadic cases of disease, rather than rare genetic variants that have been well studied, like BRCA1 and 2, and contribute to more rare hereditary diseases. These rare hereditary diseases have been well studied, like I had said, and their clinical utility has already been established, whereas the genetic variants that the CPMC study looks at have been studied somewhat, but not as well, and we're interested in learning more about their potential clinical utility. You may recognize the scale image from your reports. What this image is trying to convey is heritability, which is the estimated percent of a disease or trait that is due to your genes. About 27% of sporadic cases of breast cancer is believed to be due to genetic risk factors, while 73% is thought to be due to environmental or non-genetic risk factors, like those that Dr. Baskis has mentioned: alcohol consumption, hormone exposure, body mass index, etc. The colored balls in the genetic basket are meant to illustrate the fact that there are several genetic variants that make up this 27%, some with larger contributions to the development of breast cancer than others. The scale image on the right is there to show you that in rare hereditary cases, or families where multiple individuals have either breast or ovarian cancer, or where cancer is diagnosed before the age of 50, the percent of the disease that is due to genetics is greater than it is for sporadic cases of breast cancer. So just to give you, some background information, about 12% of women in the general population will develop breast cancer at some point in their lives. That's about 1 in 8. By comparison, between 45 and 65% of women who have the BRCA1 or 2 gene mutations will develop breast cancer by the age of 70. To put things into perspective, over 1,200 genes have been reported to be associated with breast cancer in at least one scientific publication. We give you your results for just one genetic variant within the FGFR2 gene. The specific gene that we report on has been associated with breast cancer in over 70 publications and has been shown to be associated with breast cancer in multiple populations. We only report genetic variant results to our participants that have been found in multiple studies and ideally in more than one population group, so Caucasians, Asians, African Americans, etc. Among the over 1,200 genes associated with breast cancer, there are genes that are playing a larger role in the development of cancer and genes that play a much smaller role or have less of an impact on risk. Penetrance is a term that is used to describe the likelihood that a person who inherits a given genetic variant will develop the disease or condition associated with that variant. As you can see, the variant that we report on, RS2981582, is considered a low penetrance and common genetic variant. In fact, about 70% of the Caucasian population has at least one copy of this variant, and that's associated with a relative risk between 1 and 2, which makes you at most about twice as likely to develop the breast cancer as someone without the variant. Over to the right, you can see that the more rare genetic variants are listed, and these variants are much less common in the population. So, for example, BRCA1 and 2 are about 1 in 500 Caucasians have a mutation in those genes. But they are also more penetrant, meaning that if you do happen to have one of these mutations, you are more likely to go on to develop the disease. So high penetrance genetic variants are associated with relative risks that are much greater. We're talking on the order of 10 times more likely or more to develop a disease compared to someone without the high penetrance risk variant. Only about 5 to 10% of all breast cancer cases are due to a hereditary cancer syndrome. The majority of cases are sporadic and are likely due to some combination of more common genetic variants and the environmental risk factors that we've been talking about so far this evening. Some of the red flags that would indicate that further follow-up testing for more rare genetic variants than those tested by the CPMC include early onset breast cancer, so cases that are diagnosed before the age of 50, 2 or more family members with breast or ovarian cancer diagnosed at any age, male breast cancer in the family, multiple primary cancers occurring in one person, so things like having both breast and ovarian cancer in the same individual, bilateral cancer, or you're having cancer in both breasts and impaired organs or both kidneys, for example. Cancer that's occurring in clusters, so a mother, a daughter, and a sister being affected with breast cancer or another type of cancer. Multiple generations being affected, grandparents, your generation, children, and rare tumor types and Ashkenazi Jewish ancestry. If you meet any of these criteria, please contact me and we can discuss your family history in more detail, and I can refer you to a cancer genetic counselor, which is a genetic counselor that focuses on these hereditary cancer syndromes, and that person can help you identify whether or not you would like to pursue further testing and what's the possible outcomes of that testing may be and what the follow-up it may be in terms of more screening or additional risk reduction that you could possibly pursue. Okay, I think we've talked enough about the differences between what the CPMC tests for and what we do not test for. Now I'm going to talk a little bit more about the information that we included in your CPMC report. Variant 1 is our internal numbering system. We hope to give you more genetic variants for breast cancer in the future. However, if you were to Google, you want to use that RS number, which is the scientific name for the genetic variant. RS is short for reference SNP. Below the how common is this variant box, you'll find the name of the gene and its address or chromosome, which chromosome it's on. For genetic variant 1, which is called RS2981582, it's found in the FGFR2 gene, which is on chromosome 10q2613. We also provide you with an idea of how many people in your racial or ethnic group would have the same result as you. As you can see, about 65% of Caucasians have at least one copy of the risk variant, so this is a pretty common variant in the population. So what do we know about RS2981582? This variant is located within the FGFR2 gene. FGFR2 stands for fibroblast growth factor receptor 2, and this gene makes instructions to make a protein by the same name. So altered expression of the FGFR2 gene, like that might occur with a variant in the gene, might enhance cell division and proliferation, cell movement, and possibly the development of new blood vessels. So all of these processes are things that can help a tumor grow and thrive. This specific variant has primarily been associated with an increased risk of breast cancer in Caucasian women. The FGFR2 gene, but not this specific variant in the gene, has been associated with some other cancers, so stomach, prostate, ovarian, cervical, pancreatic, and some head and neck cancers. So FGFR2 plays a role in cancer development. However, it's not as significant as the role that the more rare BRCA1 and 2 genes play. So those genes are tumor suppressor and DNA repair genes. And as you might imagine, if you have a variant or a problem with a tumor suppressor or DNA repair gene, you're at a much higher risk to develop cancer. The analogy that I like to use is to think of players on a sports team or football team. So you can think of BRCA1 and 2 as your starting quarterbacks. They're very important players that can have a very large impact on the outcome. And you can think of FGFR2 and other low penetrance genes as something more like your third string. I mean, they're on your team, but their impact on the overall outcome is less significant. So the first screen of your CPMC results is the summary screen, which shows you the relative risk graphs and interpretations for all of the risk factors that we provide you in the report. So for the breast cancer report, we gave you your risk based on one genetic variant, your family history, body mass index, your alcohol consumption, your hormone replacement history, age at first menstrual period, and childbearing history. For men, we actually only provided the genetic variant result, and this is because the variant and the other risk factors have primarily only been studied in women, so we actually didn't have data to give men, even though we know that men can actually develop breast cancer. Because breast cancer is a complex disease, we're not actually able to combine all of these risks from the genetic and non-genetic risk factors to give you an accurate risk score. It's actually something that many people are working to do in terms of making risk models to take into account multiple risk factors and give you an accurate or a more accurate understanding of what your risk may be, although we're not quite there yet. Okay, so in the genetic variant results tab will contain your risk due to the genetic variant that we looked at. So women with one copy of the risk variant are 20% more likely to develop breast cancer compared to women with no copies. Women with 2 copies of the risk variant are 50% more likely to develop breast cancer, and that's compared to women who have no copies of the risk variant. To put this genetic variant relative risk in context, the relative risk of developing breast cancer in women who have the more rare BRCA1 mutation ranges from about 14 times to 33 times greater risk depending on age. So this means that with a rare BRCA1 mutation, women are up to 30 times more likely to develop breast cancer than a woman without a BRCA1 mutation. For BRCA2, the range is, between 11 and 19 times more likely depending on age. So you can see the difference in risk between the low penetrance common genetic variant that we report on the study, which the highest relative risk that we reported was a relative risk of 1.5 versus the risk associated with the more rare but higher penetrance variants in the BRCA1 and genes that could be as high as 30 times greater risk. So just to kind of give you a sense of the impact of our variant versus some of the more rare variants that we don't test for. We provided you risk based on your family history, and we know that your family history has obviously changed over time, and many of you have been with the study for a while or maybe even several years now. So some of your information may not actually be current. You're welcome to contact me if you have questions. If you have had somebody in your family be diagnosed and you want to know how that impacts your risk, I can provide you with those updated risk numbers. The most important take-home message here is that family history is the most important tool we have for predicting breast cancer risk and for helping us identify families that may be at risk for having a more rare or high penetrance breast cancer genes. So if you have family members who've been diagnosed with breast cancer before the age of 50, if you have 2 or more relatives with breast or ovarian cancer diagnosed at any age, or any male relatives with breast cancer, we do want you to contact a CPMC genetic counselor to discuss your history further and to determine if maybe more testing that would be done outside of our study would be more appropriate for you and your family. If you were to be found to have one of the more rare BRCA1 or 2 mutations, there are steps that you can take to reduce your risk, and those include things like increased breast screening, prophylactic medications, and potentially prophylactic surgeries, depending on the situation. So again, please reach out if your family history meets that criteria. We also know that body mass index influences the risk for breast cancer. So body mass index is a tool that takes into account your weight and height to estimate if you are overweight or obese. So moderately overweight women are about 10 to 20% more likely to develop breast cancer, and these are women with a body mass index of 25 to 30, while women who have a body mass index greater than 30 are actually 30% more likely to develop breast cancer compared to women of a healthy weight, which is a body mass index of 25 or lower. Dr. Baskey spent some time talking about alcohol consumption as a risk factor for breast cancer, so I won't go into too much detail here. I will tell you that our report for women who drank between 3 and 14 alcoholic beverages per week, or as many as 2 per day, those women are 10% more likely to develop breast cancer, whereas women who drank between 15 and 21 alcoholic beverages per week, or as many as 3 drinks per day, are 30% more likely to develop breast cancer compared to women who do not drink alcohol. Dr. Baskey's also mentioned hormone exposure as a risk factor, and one of the sources of hormone exposure is hormone replacement therapy. Our risk data is based on, very specifically, on postmenopausal use of combined estrogen, progesterone, hormone replacement therapy. So women who have ever used this type of therapy are 40% more likely to develop breast cancer, while women who are currently using an estrogen, progesterone combined hormone replacement therapy are 70% more likely to develop breast cancer than women who have never taken hormone replacement therapy. There are other formulations of hormone replacement therapy, and this risk is due very specifically to the combined estrogen progesterone. So please talk to your doctor if you have concerns about hormone replacement therapy, either that you had taken in the past or that you might currently be taking. Another source of hormone exposure is related to the age you were when you began menstruating. We know that women who had their first menstrual period at age 12 or 13 are 10% more likely to develop breast cancer, and women who were 11 years old or younger are 20% more likely to develop breast cancer compared to women who were 14 years or older when they had their first menstrual period. Another risk factor for breast cancer related to hormone exposure is childbearing history. In this case, women who had their first child before the age of 25 actually have a reduced risk for breast cancer and are about 28% less likely than women who have never given birth to develop breast cancer. Women who had their first child after the age of 25 also had a reduced risk, but it was a little bit lower of a reduction, and that's about 10% less likely than women who have never given birth. The next few slides here are just to illustrate how genetic variants are passed on through families. So we're often asked if we can tell what a participant's children might have based on a parent's result. And the answer is we can't know this without testing the child directly. In some cases, depending on the parental results, if we happen to have both mom and dad's results, we may be able to infer a child's result. It really depends on what the parents have. This is because with each pregnancy, each parent passes on one copy of every gene to their child. And with each pregnancy, the copy of each gene passed on can actually change, which is why your siblings are similar but not identical. So when both parents carry one risk and one non-risk variant, there's a 25% chance with each pregnancy of having a child with 2 copies of the non-risk variant. There's a 25% chance of having a child with 2 copies of the risk variant, and a 50% chance of having a child with 1 copy of the risk variant and 1 copy of the non-risk variant. When one parent carries 2 copies of the non-risk variant and the other parent carries 2 copies of the risk variant, all of their children will actually will be carriers of one of each. So they'll have 1 risk and 1 non-risk variant because mom and dad each only have that to pass on. If only one parent is a carrier of a risk variant, then each child will have a 50% chance of being a carrier of a risk variant or having 2 copies of the non-risk variant. And if both parents have 2 copies of the risk variant, then each child of this couple will also have 2 copies of the risk variant because that's all mom and dad have to pass on. Okay, so there are some limitations to the results that we provide to you, and they're listed on your report on the limitations tab, but I'll hit the highlights. There are variants in several genes. As I mentioned earlier, over 1,200 genes have been associated with breast cancer. So no single genetic variant can completely predict your risk of breast cancer. There are rare genetic variants that exist. We talked about BRCA1 and 2 that are associated with a much higher risk of breast cancer, and the CPMC study does not test for these variants. Results of CPMC testing alone cannot diagnose breast cancer, and they also cannot rule out the chance of developing breast cancer in the future. The risk factors, like family history and lifestyle, may actually have a greater impact on your risk than any individual genetic variant. And as we learn more, your estimated genetic risk for breast cancer may change. So the CPMC study is moving towards releasing results that are based on more than one genetic variant, and that will begin early next year. At some point in the future, you might actually receive updated results for conditions that we've already covered, things like coronary artery disease or type 2 diabetes or maybe even breast cancer, that would comment on your risk due to a handful or more of genetic variants. So stay tuned for these exciting new reports. On every report that we issue, we include a What Do I Do Now tab, and this is where we list any upcoming seminars like the one you're attending this evening. We also include links to email a genetic counselor or request an appointment with a genetic counselor to discuss your results. You can also get to our educational page and video for the condition from this tab, and I would encourage anyone who has a family history that meets the criteria that we've talked about tonight to contact us for further evaluation and possible referral to Dr. Baskis and his colleagues, or I can find you someone closer to you if that's not convenient. We have a lot of educational materials on our website to help you learn more about each condition or drug gene pair that we report on, and I encourage you to take some time and look through these resources. There are both web pages with text-based information, and there's also some YouTube videos that provide an overview of the condition or the drug. You can check our website actually to see what conditions we'll be reporting on in the future. Next up in October will be obesity, followed by simvastatin in November. Simvastatin is one of the statin drugs, so I know a lot of people are interested in that result. If you haven't done so already, please complete your outcome survey questionnaires. These are the surveys that we are sending you reminders about every month. They take 10-15 minutes to complete, and they do really help us learn a lot about the utility of personalized medicine. They help us learn a lot about what you're doing with your results, if you're sharing them with your family, if you're sharing them with your doctors, if you're making lifestyle changes, even if you're not doing anything with them, even if you think these are not helping you at all. We want to know that too. That's just as important. So please take the time to complete your questionnaires. That's really the crux of our study in terms of the data that we'll need to determine how useful this information is to medicine. And just as an additional perk, the first 500 who complete a questionnaire are actually entered into a drawing for an Amazon gift card. Finally, I want to thank everyone for listening to tonight's presentation. Please don't hesitate to contact us with any questions that you may have.